So today we're going to talk about the 2019 novel coronavirus. And I just want to, before we get started, I do want to welcome everybody who's here. Thank you so much for being here. I do also want to acknowledge the people who are plugged in online through live stream. Thank you for joining us through that way. Welcome. So my name is Sanghyuk Shin. I am an assistant professor at the Soo and Bill Gross School of Nursing. And I'm also the director of the UCI Infectious Disease Science Initiative. And so tonight we're going to talk about the 2019 novel coronavirus. And as of today, and things are fluid, things are changing on an hourly basis, but there are over 40,000 confirmed cases and over 1,000 deaths. And the vast majority of these cases and deaths have occurred in China, and primarily in Hubei province. So I think we've all been sort of inundated with information regarding the coronavirus outbreak. And I think one of the challenges when we're getting so much information is to try to tease out, how reliable all this information is that we're getting. So I'd just like to start out with a show of hands. How many of you here have seen something in the news, something in the social media that you thought, okay, this can't be true, this is completely false? Right? Okay, many of you have. How many of you have seen something that you weren't really sure? It might be true, it may not be, but you're not entirely sure. Right? How many of you guys have had that? Yeah, and I think that's what the challenge is. And I think some folks have said that misinformation is the one thing that is spreading faster than the virus itself. And I think that's one of the challenges that we have here today is with all the information that we're getting, what can we trust and what do we accept and what do we reject? And so we are extremely privileged here tonight to have some of the world's leading experts on multiple facets of this outbreak here with us today. So hopefully after this event that they'll be able to shed some light on sort of how do we sort of make sense of all the information that we're getting. So I think how we're going to do this, how we set this up is we're going to have our featured speaker, who is Dr. Matt Zahn from the Orange County Healthcare Agency. And he will give us a sort of an introduction to the coronavirus outbreak that's going on, so sort of an overview. And after he's done his talk, I'm going to invite our UCI panelists up here, and I will at that time introduce each panelist. And then we're going to go ahead and start out with some questions and answers, and I will start out with a few initial questions, and then we'll open it up to questions from the audience. And we have mics set up in these aisles so that the audience members can go up and ask questions. So before we get started, I do want to just remind everybody to turn off your phones or put them on silent. And also just this event has been organized by the UCI Infectious Disease Science Initiative and also multiple partners, including UCI Health, the Soo and Bill Gross School of Nursing, School of Medicine, Department of Statistics, and Donald Bren School of Information and Computer Science, Program in Public Health, and UCI Student Health Center. So thank you so much for all the sponsors and co-sponsors for allowing this event to happen. So with that, I'd like to introduce our featured speaker. It's Dr. Matt Zahn. He's the Medical Director of the Division of Epidemiology and Assessment for the Orange County Healthcare Agency. And Dr. Zahn has been at the forefront of outbreak response and preparedness here in Orange County. So let's give him a warm welcome.
Thank you, Sanghyuk, and thank you all for showing up. Everybody hear me okay? Microphone right? Okay. So yeah, what I'd like to run through for you here is a bit of the overview of what we've seen for the 2019 novel coronavirus outbreak internationally. But really, not surprisingly, my job is in local public health here in Orange County, so my focus is going to be on our response and what went on in our response so far and what we anticipate in the future. So briefly, to make sure we're all on the same page here, I think there's been a lot in the news, but to be clear, the start of all of this was identified really when some clinicians, physicians in December in Wuhan city in Hebei province in China started reporting that they were seeing patients with pneumonia of unknown etiology. And that kind of information sort of percolated around, and there was some awareness of it, but right at the end of the year, December 31st, Wuhan Municipal Health Commission reported this officially. It said out loud, there is a cluster of pneumonia cases of unknown etiology. They had they had more pneumonia cases than they were expected to see in that community, and they were testing them for the regular quote-unquote type of infections processes, and they weren't finding them. There did seem to be growing a apparent common link to the Wuhan's Hunan seafood wholesale market, so a fish and live market, animal market of considerable size in the city. And just again to give people a sense here, just the numbers in China, and population numbers are always impressive. So Wuhan is 11 million people, that city, so slightly larger than the city of Los Angeles County for perspective. Now, the velocity of all this, to me, is actually extraordinarily impressive. So if you start that in December, these unusual number of illnesses are identified. On 31st, the commission makes a report. On January 1st, that the market of concern was closed. And January 8th to 9th, China's CDC announced that they identified a coronavirus that seemed to be the causative agent. And there's certainly been a lot of communication or concern about how quickly China has responded to this event, and I claim no particular insight into that. I would say, though, just in terms of velocity to, within a matter of weeks, identifying, one, that there's an outbreak, and two, that there is a specific etiology identified is pretty extraordinary. On January 21st, the first United States case was confirmed in Washington. On January 25th, we had the third case, so we lost to Chicago, but we beat Los Angeles by half an hour, and I'm a little bit proud of that. And about that time I said, well, I think I'm going to be giving a talk at UCI about coronavirus, and so maybe people will actually show up. But this was a big deal, obviously for us. It was the third case identified in the country, and on January 30th, WHO declared a global public health emergency related to this event. And February 4th, again, just to get an appreciation of the velocity that we're talking about here, on February 4th, so last week, the FDA issued an emergency use authorization for CDC's test for this virus to be distributed out to labs around the country. So the CDC lab was already doing this test, and again, now it has been distributed, and labs around the country are going to start putting it in action. I would say, in terms of velocity here, that is really extraordinarily impressive in a lot of different ways. This is a review from a article in The Lancet, a medical journal, talking about the first 41 cases that were identified, reported from a local facility. Again, noting a couple of things. One is that there was an awful lot of a connection to the seafood market, but certainly they were also seeing cases that didn't have an apparent connection to this market, and relatively quickly there did seem to be some evidence that there was person-to-person transmission even within the first few weeks of this event being identified. The other point that was really noticeable is, so these were 41 patients. They weren't 41 patients who were just there. They were 41 patients who were hospitalized, so all of them having a significant burden of disease. And if you look the red versus the blue, the red there is patients who needed to enter the intensive care unit. And so a couple of things to note here. I think that what they've seen in Wuhan has been really not only illness, but significant illness. But the other thing I think for all of us to realize when we're thinking through the epidemiology of this is an awful lot of the initial data is for people who've had the most severe disease. We've learned an awful lot very quickly, but I think we still have a lot to learn about people who have more mild disease, people who do not need to be admitted to the hospital, and what populations are affected that way. So I think it's just worth recognizing that. Now, outside of China, and this is just a beginning of an epicurve, these are the cases that are all identified in China in Wuhan, then later on in other parts of China. You can see that really there was spread in a significant number, and really cases that were outside of China as well. So these are all people who were diagnosed outside of China, but the vast majority had a history of exposure to Wuhan, but not all of them had traveled from there before they developed disease. Right now, as was mentioned, over 40,000 cases as of this morning. We looked at the WHO website. It's over 900 deaths. Worth noting, still, of those over 40,000 cases, 29,000 of them have been identified in the initial province, in Hebei province. So there still is a real focus of disease there. And the overwhelming percentage of 40,554, 40,235 are in China. So still, in that country, the overwhelming burden of disease is focused there. But recognize also there are now 27 different countries already that have reported a case of novel coronavirus disease. So 27, that's obviously including the United States, but that's extraordinary. Again, the vast majority are still reporting travel recently from Wuhan. That's how it's being identified, but that's an awful lot of countries where at least some illness has been identified in a pretty short period of time. In the United States, 12 cases identified thus far, 6 of them in California. Right? So one here, one in Los Angeles, 2 in San Benito County, and 2 in Santa Clara County. And this is not, of course, accidental. If you look at international travel, particularly travel from China, really California is one hub. It is a center for an awful lot of travel from China, so it's not a huge surprise. I think it is worth noting, this is something else we're all paying a lot of attention to. Of the 12 cases, 10 of them are people who developed infection after travel. Only 2 of them so far are people who have developed infection here in the United States after exposure to someone else. So one, it's proving one more time, yeah, it certainly does pass person to person, but the number of people who become infected after those initial cases, after exposure to those cases, is another part that we're going to pay a lot of attention to for sure. So again, talking about our experience in Orange County for our case, just to give you a sense of how we think through this and how the response looked. On the January 25th, which was a Saturday night, the CDC contacted us to say that someone who had been tested had tested positive. And I will tell you that there have been a tremendous amount of interest in the community about our person's clinical course, specifically him. I'm not going to talk through his specifics out of respect to him. I will tell you that our experience with him and his clinical course is very consistent with what's been seen on virtually all of the reported cases so far in series. So it really is consistent with what they've seen. He had a respiratory illness, again, similar to what's been seen in the literature. He was admitted for a period of time to monitor him closely. He never became seriously ill, but he was watched for several days in the hospital to make sure he is doing well. He is now clinically improving. And so to talk through a bit about coronavirus, and I'll talk about disease in a second. Coronaviruses they've been around since the 1960s, and there are several coronaviruses that cause the common cold, and that's been noted. It is a single-strand RNA envelope virus. It has a lipid membrane, and the reason that matters to us is lipid membrane viruses tend not to survive well on surfaces or on fomites. And that's been the general experience with coronavirus, because one of the things you think about right away for a virus is what are the way you acquire it, and obviously I'll talk about that a bit more as we go along. And it doesn't seem that it's an enormous risk in terms of fomites or exposures, but from what we know about other coronaviruses, but that's clearly something still to be figured out. Coronaviruses, habitually, bats are the reservoir of choice. If you look at experience with other coronaviruses, sometimes they can evolve through other animals and infect other animals, but bats tend to be the reservoir. If you look at the family, again, there are 4 coronaviruses who aren't terribly important to us other than to realize those 4 coronaviruses listed, they commonly cause human disease. They cause the common cold, and they've been around for decades. So it's not as if we never see coronavirus. But 2019 novel coronavirus is a different strain, clearly. The SARS outbreak back in 2003, the outbreak of MERS-CoV in 2014, those are both coronaviruses, and those were hallmarked by they pass person to person, though not terribly well, but they certainly cause serious respiratory disease really significantly. So it's not as if we haven't seen anything like this from coronaviruses in the past. This is a review. I'm going to talk through a review, probably the most complete review of patients who've been identified to have novel coronavirus infection. This is again out of Wuhan, and this is a single center study. This is 138 patients who were admitted to one hospital in Wuhan. And again, I think it's important to note, they're reviewing the patients who were sick enough to be hospitalized. So we're learning a great deal about serious disease, but not necessarily how much or how vast more mild disease is. A couple of things to realize. One is the median age is 56 years, ranged from 22 to 92 years of age. There has been a notable absence of description of pediatric disease thus far. Really, under 25 years of age is when the disease burden seems to fall off a cliff. Doesn't mean that there is none, right? Doesn't mean it at all. It just means that what they've seen in terms of serious disease certainly is weighted toward the older population. Of this population, a quarter of them ended up going to the ICU, so very sick. Why do they go to the ICU? ARDS, acute respiratory distress syndrome, severe lung infection and inflammation leading to pulmonary failure. That's the primary driver, but they've had other reasons associated with cardiac arrhythmia, and they have a shock. They've described a shock-like syndrome that goes on with this illness as well. People who have underlying medical conditions, diabetes, hypertension, cardiovascular disease, if they looked at all the people who were hospitalized, those who were most likely to be in the ICU had some of these predisposing risk factors. Incubation period for this group was about 5 days. For this group, it was some exposure to that market that people tended to figure was the initial exposure. And so somewhere around 5 days after the exposure was when illness began. And this is an important part of what we're seeing here and something that we're going to have to think through how to respond to. If you think about influenza, you get exposed to influenza, within 1 to 3 days you get sick. Within a couple days, if you're going to get bad sick, you tend to get bad sick. The virus kind of declares itself relatively quickly. One of the difficulties about this virus is the median duration from first symptoms to difficulty breathing, we call it dyspnea, having shortness of breath, was 5 days. Okay, so someone would get some fever, cough, and would kind of hang around, and then several days later was when they'd start getting sick. Admitted to the hospital a week after the symptoms started. That ARDS, that really severe pulmonary disease, that was 8 days afterwards. And so that's really one of the difficulties we're going to have. For our patient before he went home, not tremendously clinically ill, but like all the other patients in the United States that the CDC is working through, and we were talking to the CDC every day about how to manage this. The concern is we know that this is a creeping sort of disease where after the first few days, maybe you're not terribly ill, but in a couple days later, you could be more ill. And so how do you manage that? I think we have to learn more about how to get a comfort level about exactly where to manage it. This is a chest x-ray of one of the patients described in this write-up. Fever overwhelmingly present, so vast majority of people had fever. And again, shortness of breath happened in about a third of people, so it didn't happen every single time, but it certainly happened. They did report diarrhea 10% of the time, and so that's a little bit interesting because we think of coronaviruses really as overwhelming respiratory disease, but it does cause diarrheal illness as well, and so that's going to warrant monitoring as well. A couple of laboratory findings that they found consistently is evidence of liver inflammation, so AST, ALT. So enzymes in your liver the levels get elevated in your bloodstream when you have infection because apparently there's some liver inflammation going on. It's not the vast majority, but it's something that seems a bit peculiar to this illness. Pneumonia in general is not something you will see evidence of hepatitis, so this is something a little bit distinct. Lymphopenia, so a lower lymphocyte white blood cell count in your bloodstream. This is not, again, something that you'll definitely see this with viral infections of any kind, but this has been pretty notable. They've pretty consistently seen a lowish white blood cell count for patients who are infected. How do you test for this virus? Right now, and the way we tested our case and the way it's really being done around the country, you get a nasopharyngeal swab, so a swab up your nose, oropharyngeal swab, so a throat swab in the back of your throat, and a serum test. And that's really the standard way that's being, and it says, it identifies coronavirus as RNA, but DNA, but it identifies coronavirus RNA, this test. How sensitive is it? Well, it certainly seems to be identifying an awful lot of disease. Of course, mild infection, could it miss? We're still figuring that out, right? But the test certainly seems to have been consistently able to identify infection. There's two ways it's being used right now. One is to identify infection, and the second way is to document clearance, to figure out, because all of us are trying to figure out for an indolent infection like this, when is the person not infectious anymore? You know, for us, our case has been home for several days, but is still in isolation because we're trying to figure out with the CDC exactly when you don't have to worry that that person is infectious at all. One of the ways that we figure that out is by doing repeated testing of the nasopharynx and the oropharynx to see if there's evidence of that virus around. Yeah, and I'll go back to the last bullet point, which is our lab in Orange County. We have a fantastic lab at our local health department, and so our lab is one of the many that has received reagents and is trying to start putting through the process of being able to test for this virus on a local level. Right now, all of these tests, every single one of them has to go to the CDC. There's a lab in the CDC that's doing this test. And for us, that's no small matter, because if you want to test somebody, that means the result may come back in 5 or 6 days. That's not a simple thing to tell someone, I'm worried about if you have infection. If you're not bad sick enough that you need to be in the hospital, go home and stay home and don't go anywhere, and I'll call you back when the result comes back. We'll feel a lot better. We'll all feel a lot better when we're able to do this test locally. In terms of treatment, there is no specific antiviral treatment recommended. It is treatment of symptoms. If you give them oxygen to help with hypoxia, you give them IV fluids to help with dehydration, but there isn't a specific treatment. One of the big questions that we always use in inflammatory infections like this is there a benefit to using steroids? Steroids are inflammation reducers, and sometimes we'll try to use that to modify severe disease. The CDC has been pretty definite about saying don't use that. It's an anti-inflammatory, but it's also anti your immune system, and so there's downsides to using it, and so they've been pretty definite about not using it. I mean, just to give a sense about where we are in terms of antivirals, remdesivir is a nucleoside analog. It's an antiviral that's being in China. Gilead is partnering with the health authorities in China on a randomized trial. But I think realize here that this is not an antiviral that has been used before to effect. This is an antiviral that's been proven to work in animal models. So we're a long way from saying this or any other antiviral is a treatment. I think we'd all like to get to that point, but I think we have to be clear that we are a fair distance, months or years, from having a specific antiviral treatment. How is the virus transmitted? If you pay attention to the literature and how the CDC is going about this, so this is a new virus. This virus has been around for a month, right? And so an awful lot of our thinking surrounds around what we know about other coronaviruses. In general, for coronaviruses, close contact with people who have a cough are those who are at risk. So person-to-person spread happens when you cough or you sneeze and you have the virus in your secretions and they get on the other person, okay? We always worry about airborne spread, meaning that I have it here and then the people in the back may be exposed. That airborne spread has been identified at times in other coronaviruses. Right now, where's the money? The money is probably people being in close contact, coughing on each other. That's where it is. We always worry for any virus about how it can be passed from fomites. I touch the doorknob that someone who has coronavirus has. It's hard to say that's not absolutely a possibility, but that, again, doesn't seem to be where the money is. It doesn't survive on surfaces, coronaviruses, habitually. It's people coughing on other people, sneezing on other people. That's how it gets passed. For our response, for our individual case, and again, I'm not going to get hugely into specifics, but I'll tell you a couple of things about it. One is that the system worked in that he came through an airport, he was apprised of the situation, he knew about the concern, he went to a medical doctor, and most importantly, before he went in, he wore a mask, and he walked right in the door and said something to the effect of, I'm from Wuhan, and I'm worried about having coronavirus, you know, and that's number one. And number two, the greeter, the first healthcare workers to see him recognize the problem immediately, said, okay, go right back outside, wait outside, we will get the airborne isolation room ready, and then you come back in and get seen. And so for us, that person is the healthcare person of the year for me in Orange County, because you know, I don't know the other numbers of all the other cases. You know, people are all being a little quiet about exactly all the cases, but I know that there are other situations where people have waited in waiting rooms. If you wait in a busy emergency room for an hour and you can't say that airborne precautions are an issue, then there can be potentially an awful lot of patients, an awful lot of staff exposed. Our numbers have been really significantly lower because he understood his situation and they understood the situation at the facility, and they saw him quickly. Even with this, so you know, give numbers here, 3 close contacts, that means some combination of people who are good friends or family members, stayed overnight in the same house, those sorts of things. We have 3 people who would fit into that category. We have about 30 to 40 people who are healthcare workers. And for all of those people, we have been calling them every single day to see if they have symptoms, every day. You can guess that for us, who would be the people that you'd worry about the most? Well, the people who are really close contacts who've been in the same, you know, in the same household. At this point, they have been more than 14 days from exposure to him and have not developed illness. And so really those were the people that I think were at the highest risk. They haven't seen symptoms yet. Then there are others of us. Even if you were a healthcare worker and you did all the right things, you put on all the right PPE, we're still monitoring you. I saw him, not to take care of him, but to interview him. And so I'm being monitored and taking my temperature every single day. I'm doing fine, thanks for asking. But you know, so you know, at this point, we still have people that we're still monitoring, because when he's in the hospital, even if everybody knows what they're doing the right thing, at this point, because we're learning about this virus, we're still interviewing all of those people every single day. In terms of the international response, I mean, I think everybody kind of, you know, has to be aware so far of what we've seen, and it's certainly been extraordinary. I will say locally, so there's been more social media noise from this than anything I've ever been close to. I will just pick out 2 of the fraudulent social media things that have come out. And so these are things that I've had texted to me or forwarded on to me. Aha, I know this person, we know who the person is, they were here and they were here and they were here, and watch out. It's all wrong. It's all been totally, completely wrong. If it were right, I might not tell you, I'll admit that, but I'm telling you the truth. It's all wrong. None of it has been anywhere near reality at all. The second one, the one on the left, I think is really interesting because it has the WHO on the top and the CDC, and it announced there was an outbreak in the area. None of this is right, and so, you know, for us, it has, you know, one, just pushing back on that misinformation is a big deal, and 2, I'd say it's really important, you know, to realize that there's an awful lot of stuff out there that, you know, I think Sanghyuk mentioned it, just ain't so. I will, you know, I think everybody was aware of on January 31st, the White House announced the proclamation to suspend entry of immigrants and non-immigrants for non-U.S. citizens into the United States for anybody who had been in China within the last 2 weeks. In public health, you know, that kind of takes our breath, because I mean, I've only been doing this for 15 years, I guess, but you know, it's been decades and decades, and we haven't done anything like this. So this is a big deal. I think it's a big deal for us in terms of how we think through appropriately responding to this directive, and it's a big deal in terms of recognizing how significant the risk here of this event is internationally, and the risk is not small. So for non-U.S. residents who've been in China within the last 2 weeks, they're not to come to the United States. If you are a United States resident and you're returning from Hebei province, so the province with the highest risk for, you will be come to the United States, but then you will be monitored at a site by public health somewhere in the country. And I think we all watched March Air Force Base we had 200 returnees from Hebei who are there right now, and other sites around the country where people are being monitored and quarantined. Now, for return travelers who are United States residents who are coming back from outside of Hebei, so for this population, really they're going to sites, and really they aren't sites in Orange County, so it's not something we've been at the center of. For United States citizens returning from other sites, we definitely will have people who return from China to Orange County, and that we are being sent lists of people who return, and we are going to reach out to them. That list, that number's in the hundreds. For us, functionally, what it means is those returning travelers from China, they're being educated when they return through airports that they are recommended to stay home. It's not quarantine, but don't go to work, don't go to school, avoid public gatherings, right? This is not a quarantine at home. For them, they can go get groceries, right? And this is not, you can't leave your house, but it's to try and avoid public settings in the event that you develop illness. For us, we have been making initial contact to this group, and we will contact them at the end of 14 days to assure that they haven't developed illness. But this is not, we're not sending work exclusion or school exclusion letters to people's houses. And I will tell you that we are getting calls from people saying, and you laugh when you think about it, but people saying, well, I have a work, someone who works with me, and I really think that he or she came back from China in the last 10 days, and they seem to have a cough, and what do I do about that? I mean, this doesn't work that way, right? I mean, I think that we all have to realize that, well, every single person who comes through adhere to this. I don't know that that's so. I think the vast majority of people will, and that's the way that this works, not us policing other people, recognizing that people are being given the directive and they're adhering of their own, of their own decision. And I think it's terribly important for us, because in public health, this is not something we take lightly or do all the time. And so I think maintaining that relationship with the community is terribly important. Where should a person be treated? Ideally, really, it is a place to go where there's an airborne isolation capacity, where there's negative pressure rooms. Most hospitals, most emergency rooms have that capacity, but it's really important. We're trying to get people to understand, if you think you're at risk, call the facility beforehand. Please don't walk into the emergency room, wait in the, in the waiting area, and then figure out there's an issue, and then there's a large concern. For hospital settings, there's Dr. Wen Liang, I believe is his name. This is his picture. He was one of the first clinicians who identified a problem in Hebei and eventually became sick and died of this illness. And this is really upsetting, I think to all of us. But I would also point out that there's an important message here. SARS, MERS, an awful lot of the people who've gotten sick in those outbreaks have been people who've gotten sick at hospitals. And in a way, it's not a huge surprise. For SARS, when are you the most infectious? When you're your sickest. Where are you when you're your sickest? You're in the hospital. That initial case report I referred to said that 41% of their cases developed illness apparently after a healthcare exposure of some kind. They're a healthcare worker, or they're a patient who is in a hospital. I don't think that 41% of all the cases out there by any means are healthcare related. I think it's a much smaller percentage of that. If you're in the hospital though, it's easy to identify those cases, right? So that's their event is weighted toward identifying the people who are already there. But I think it's really, really important for us to realize that patients need to be seen, treated well, but they also need to be treated safely, for sure. In terms of precautions, N95 masks, gown and gloves. I think that if my observation for healthcare workers is by now everybody's aware of airborne, so they know about their N95 masks, they've had themselves tested, and they know to put it on, and the gown and gloves, that's natural. Eyewear, eye protection is not something that they do as naturally, for all of the medical staff who had some exposure where they weren't doing appropriate PPE in the relatively small number, mostly it was they weren't wearing eye protection, and so that's a big emphasis for us. So, I end up breaking down in I'm relatively simple-minded, so, what do we know? We know that this is a virus that can cause severe, particularly respiratory disease. We know that person-to-person transmission is happening, and we know that there really is already a broad geographic distribution of this virus. This is actually from the New York Times, but their title was "How Bad Will the Coronavirus Outbreak?" And that's actually not that bad of a depiction. The point of this, I would say, is on the y-axis is the fatality rate, how bad the virus is. Not as bad as SARS, probably not as bad as MERS. But it's pretty significant. It's nowhere near the common cold. If you look at the x-axis, how infectious is the virus? Well, you can see measles is way out there on the end. Measles is way more infectious than this virus, but it's pretty infectious. And so there's really an in-between of this virus that, number one, it seems to pass reasonably from person to person, and it does seem to make a fair percentage of the population sick. So the question, is will an outbreak happen in the United States in Orange County? I mean, that is, I'll admit, the thing that keeps me up at night and I think about all the time. And I will tell you that the information is coming so quickly that about every 3 days you learn a little bit more. And I've kind of accepted that. I don't think anybody exactly knows the answer to this right now, but in a couple of weeks, I think there's a good chance we'll know a lot more. I think we all know that there is certainly a substantial risk that this outbreak will carry to the United States, and we will see person-to-person transmission either in Orange County or other parts of this country. But there's a lot of stuff that we don't know. So how often does infection lead to serious disease? Again, we've identified an awful lot of people that have gotten seriously ill, but what's the denominator? How many people have mild illness? Still don't know the answer to that. What drives it? In SARS, as I mentioned, super spreaders, people who were bad sick, who were extremely infectious, that was the driver of SARS. That's why so much of SARS infection was healthcare related, because they're really the sickest people, the biggest drivers. But what about people with mild illness? How much of a driver is that? I attach that to pediatric disease. Again, there's very little of it reported, but if you think about flu season, pediatric patients are an awful lot of what spreads this through our community. So is there a potential that either they are at risk for significant disease, or are they passing the virus? We don't know the answer to that. The WHO feels like asymptomatic setting is unlikely to be a large driver, and I think that's probably true just of our experience with coronaviruses in general, but I think we have to learn a bit more about it. When do you become infectious? Can you be infectious before your symptoms start? For flu, for a day before your symptoms start-ish, you can be infectious. That's one of the reasons it's really hard to prevent flu outbreaks. Coronavirus habitually, the infectiousness really seems to start when your symptoms start. We have to clarify this. And then when are you most infectious? Again, right when you start or when you're most sick? All of this has bearing on how likely this event is to spread to the United States and spread around the world. So what you can do, now, I know you're all gonna laugh and say no matter what we say, we always say in public health you can get your flu vaccine, right? Like if there's a meteor headed to the earth, public health would say get a flu vaccine. But there's actually logic here, and this is actually important to me and important to us. If this virus comes here, and again, we have no certainty of that, but that's certainly at least a possibility. What we don't wanna have is flu season and this season at the same time. For emergency rooms and hospitals to be full of both of those outbreaks at the same time is a really, really big deal. Right now, we have an awful lot of returning travelers who have cold and flu-like symptoms, and overwhelmingly, they probably just have flu. In fact, most of the time we find out they got flu. They don't have this virus. But to be able to separate it out, so to speak, to be through flu season before all this, I think we don't want it to come at all, but if it does, that delay of time where we can learn more about the virus and we can potentially get through flu season, I think will be valuable to us. I'll go ahead and stop there, and I think questions afterwards? Yeah. Okay. Thank you all for your time.
Thank you so much for that, that incredibly informative talk. That was really great. Thank you. So now I'm going to go ahead and invite all the panelists to come up, including Dr. Zahn. And I'll go ahead and introduce the speakers. And I just want to note how, what a difficult task it is for Dr. Zahn to put together a PowerPoint presentation like that, because I'm sure he was busy this morning updating all the numbers, because things are changing so rapidly. And in fact, we could probably invite him back tomorrow to do a brand new presentation with new information that have developed. So at this point, I'm going to go ahead and introduce our panelists. So we have, starting from to the farthest to your left, we have Dr. Michael Buchmeier, who is the professor in the Division of Infectious Diseases and Associate Director of the Center for Viral Research here at UC Irvine. And he is, in fact, a leading expert on coronaviruses with over 65 publications on that topic. And then we have Dr. Andrew Neumer, who is Associate Professor of Population Health and Disease Prevention. Dr. Neumer has expertise in infectious disease dynamics with a specific focus on historical outbreaks and influenza pandemics. Next, we have Dr. Vladimir Minin, who is a professor of statistics. He's an expert on molecular epidemiology and how diseases transmit. Then we have Dr. Albert Chang. He is the director of the UCI Student Health Center and has been really at the forefront of making sure that our campus is safe and prepared. Next, we have Dr. Shruti Gohil, and she is with the Division of Infectious Diseases, and she's the Associate Medical Director of Epidemiology and Infection Prevention at the UCI Medical Center. And so she is responsible for procedures to keep patients and providers safe from infections at the hospital. And lastly, we have Dr. Allison Holman, who is an associate professor at the Sue and Bill Gross School of Nursing. And she is an expert on sort of the population health and population effect of media coverage of outbreaks. So I'm going to go ahead and start with a few questions to start us out. So the first question I'm going to pose to Dr. Buchmeier. And so Dr. Zahn gave a really great overview of coronaviruses in general. And I wonder if you can expand on that. So what do we know about coronaviruses in general? And how does this 2019 novel coronavirus compare with other known coronaviruses?
It's on. Okay. Coronaviruses are not unique. They're not rare. If you have a cat, you take your cat to the vet every 2 years, and you get vaccinated for coronavirus infection. If you have children, you probably have had a respiratory coronavirus infection in the family. They're unique in that they're, for the most part, fairly harmless. But on occasional situations, they will mutate and become extremely virulent. Your cat is vaccinated not because of the mild coronavirus that he carries or she carries, but because that can mutate to something called feline infectious peritonitis that will kill the cat in 10 days. And so you have kind of a dichotomy between the very mild disease and a very serious disease. So in the coronaviruses of humans, SARS, MERS, Wuhan, we're looking at a disease that can be very, very mild, as it is perhaps in people under 25 who show no symptoms or just mild symptoms, to deadly in people that are advanced. I think another factor that should be considered is smoking as an issue and respiratory compromise because of smoking. In China, the respiratory rate, the smoking is very high, the rate of smokers. And so you have to also factor in that respiratory sensitivity in adults, especially older males. This virus is really a very, very close first cousin of SARS. It's the initial attempts that we made to sequence it and others and compare it to SARS showed that it had a very, very high degree of similarity with SARS. So it's not really a new virus to us. It's a virus that we have seen before in another capacity. When we looked at SARS, one of the things that we saw during the course of the epidemic, which lasted about 6 months, was that the virus changed in time. So there was a very detailed study that was done in southern China that showed that there were at least 3, perhaps 4 different viruses circulating in palm civets during the course of the whole run of SARS infections. And so you see a virus that is not just a stationary target, but it's a moving target. And those changes have to be considered when you consider the virulence of the virus. So I'd be happy to talk to anybody who wants to about what the details of that are.
So I do have a follow-up question, Dr. Buchmeier. Thank you for that. And you did mention the vaccines that are currently available for cats. And so the natural question, of course, is, so what are the prospects of developing a vaccine for this novel coronavirus? And what is kind of the expected timeline?
It's a cultural thing that we have to live with, that we can develop a vaccine very quickly for cats. We can develop a vaccine for West Nile, which protects horses, but we don't have a vaccine for humans for coronavirus or for humans for West Nile. And that has to do with the regulatory process and the very high hurdles. In the pharmaceutical industry, that's called the valley of death, where good ideas will die. And I think we have to understand that that's part of the landscape. It's much easier to make a killed vaccine. And a killed vaccine would be something like we're using right now for flu. That's an easy vaccine to make because you're dealing with a protein, and that protein is not harmless by itself. And so during the course of SARS, we saw seminars where people from Novartis, for example, would bring a construct, it's a molecular construct that's made in vitro, which represented the spike protein, the major glycoprotein on the virus, and it protected 100% of the experimental animals. That was put on the shelf when SARS disappeared, like a lot of good ideas. And things like that exist in the scientific literature and could certainly be revised and regenerated now.
Okay, so my next question is for Dr. Neumer, and Dr. Zahn presented some very beautiful graphs about sort of contagiousness of the virus and of the case fatality rate, and I wonder if you can expand on that a little bit. And from the data that are publicly available, that are being produced in China as well as elsewhere, what do we know about how contagious this virus is, and how I guess a follow-up to that is, how serious is this infection? So what is the case fatality rate? How likely is it that if one gets an infection, that it will cause serious disease and potential death?
Thank you. The graph that Dr. Zahn put up in I think the second to last slide, which showed a big orange rectangle for the novel coronavirus, region of uncertainty, I think that's so important to understand that we're still, all the other viruses on that plot still have dots because we know what their contagiousness is and we know what their case fatality rate is. And for the novel coronavirus, the data are still coming in, and we're still in the time period in which we don't fully understand, precise estimates of contagiousness and case fatality rate. The horizontal axis of that graph was a little bit mislabeled in the sense that it was plotting R naught on the x-axis, but R naught is not the number of cases that each new case will generate. And this is always a source of confusion when we have a new epidemic, and R naught is in all the newspapers, but R naught is the number of cases that a new case will generate in a completely immunonaive population. So in a population in which everyone is susceptible. And so as the epidemic progresses, there will be asymptomatic cases or very subclinical cases where people will be exposed and then recover and be immune. And the R naught number no longer represents the infectiousness of a single case at that point because there are now immune people in the population. So that's something that's very important to understand. And also, it's important to understand that R naught is a measure of a virus's ability to spread in a population. So the population density in Wuhan City or Hubei province may be different than in Irvine City or Orange County province. So R naught is not a single number that's a property of virus. It's a property of the interaction between virus and the people in the society. So we have to understand the social aspects of the epidemiology, not just the stuff that Mike studies in the lab with the viral particles themselves. The case fatality rate for the novel coronavirus seems to be around 1%, but even that number is not a definitive number yet. So it's lower than SARS, it's higher than seasonal flu.
Thank you. And can you briefly mention, because given your expertise on historical flu pandemics, so how do historical outbreaks and pandemics, what do they teach us about the current novel coronavirus outbreak?
Yeah, the word pandemic sort of strikes fear and panic, but a pandemic is a novel pathogen that spreads at the global level. And so with flu, we saw pandemics in the 20th century and 21st century in 1918, 1957, 1968, and 2009. And so the 1918 pandemic is always sort of trotted out as a horror story, but it's important to remember that the 2009 pandemic was also a flu pandemic. It was also a novel strain of flu that spread around the world. And who remembers the calamity of 2009? Well, nobody, because it was a pandemic, but it wasn't catastrophic. And so the coronavirus pandemic that we're on the threshold of experiencing worldwide now is not necessarily going to be a calamity. It's going to be a new virus that spreads, and that will just like the 2009 pandemic will eventually go away, just like SARS did. I don't think we're in 1918 territory based on the spread and the case fatality rate.
Thank you. So the next question is for Dr. Menon. So based on statistical and mathematical modeling that researchers have been doing for the past few weeks, what do we know about the likely trajectory of the outbreak globally and here in the U.S.?
So mathematically and statistically, what these models, mathematical and statistical models, can answer the two broad questions. One is what we are not seeing. So what are the hidden quantities that we would like to see but we don't? So one of them is important. An important one is what are the total number of infections that right now that happened in the world. That's something we almost could never observe for any infectious disease in large population just because of what's called underreporting. So each case, each infection has certain probability of being reported to the surveillance system and being recorded in a database. That probability is usually definitely not 1, it's much lower for most of the infectious diseases, and that's something that is not easy to estimate right now in the early days of the epidemic, but we definitely know that not all the cases are being reported. So how many cases we're not seeing, that's a big unknown that models can, mathematical and statistical models with certain assumptions can answer this question. Dr. Neumer mentioned the R naught, that another unknown quantity that we can start measuring and that people have been estimating that quantity, which right now is somewhere between 1.5 and 3.5. We don't know exactly where it is, but that's the range. And the reporting rate itself, what's the probability of a case being reported? Unfortunately, that number is changing over time as well. It's not constant, but we are trying to understand this number better. And the second way in which we can use mathematical models is what Dr. Shin alluded to, is the prediction. We can play the what-if game. So what if we restrict international travel by 90% and we restrict transmission by 50% by implementing certain policy measures? What it will do to the epidemic. And so, again, if we have good models that are informed by the data, and that's important, they're not just dreamt up models, we can start asking those what-if questions, and the policymakers can use those predictions to implement certain measures or not implement if they're disruptive to human life. We have to remember that restricting travel, movement, quarantine, all of these measures are incredibly disruptive for our way of life. So do we know that they are effective? It's important to understand and know whether they're important or not, and by how much we're willing to sacrifice of our lives and so our day-to-day lives in order to maybe reduce something by only small fractions. So that's how people right now kind of around the world are racing to collect data and inform these mathematical models to answer these two kind of broad classes of questions. Right now, the honest answer to your question about global spread is we don't know, because we don't know so much about the virus and how quickly it transmits, and we don't know how effective right now the policy that Chinese government is implementing, the travel restriction, quarantine, all that, how effective this is for containing the virus, for example, and so on. So I think we will know much more, but again, maybe in a couple of weeks or maybe a month, we will know more. But right now, again, possibility of pandemic definitely is on the table, but whether we will start seeing huge numbers of human-to-human transmission in the various parts of the world, we still don't know that.
Thank you. So another follow-up question. So Dr. Buchmeier mentioned that the virus is constantly mutating, which is what viruses do. So can you tell us a little bit about sort of, what are the chances of the virus becoming even more dangerous than more virulent than it is now? And what are your thoughts about that?
So every time a mutation occurs, an outbreak occurs, we talk about mutations because viruses and as a lot of infectious disease agents mutate at a very fast rate. So I want to start with the good news. It's good that viruses mutate in some sense because they provide information to us. So the virus mutations, when we see them, we actually can use this information to understand how quickly they're spreading. If we're seeing lots of mutations, that means we're seeing lots of infections, and that allows us to estimate the rate of growth and help inform these mathematical models I mentioned before. So mutations are good in some sense. So viruses do mutate, and that's a good thing most of the time. Although the possibility of virus becoming more dangerous is always on the table, to be honest, we have seen these emerging outbreaks, Ebola, Zika recently, and all of them, there will be at some point a panic of in the news saying that there's a new mutant virus that will be highly virulent and will infect people at higher rate. So far, we don't have a lot of evidence that this is happening all the time with emerging infectious diseases. So a lot of times these mutations are what they call neutral, in the sense that they don't seem to be doing a lot. There are exceptions, certainly. There's no question around it. But in my opinion, I'm more watching mutations as a source of information rather than something dangerous to watch out for.
Thank you. So the next question is for Dr. Chang. Can you talk a little bit about the measures that are in place at UC Irvine to prevent transmission? And maybe briefly touch on, there have been calls to cancel classes and some kind of, drastic measures. And if you can talk a little bit about that.
Sure, Dr. Shin. So, one of the first things that we did, and we've got strong partners here at the table, we were in contact with UCI Health, we were in contact with the Orange County Healthcare Agency to really see what the true data was, what the information was. And like Dr. Zahn mentioned, there was a lot of stuff going out there. And unfortunately, it was being shared amongst students, amongst parents. And so making sure that we were approaching this with kind of a clear mind and kind of a clear target. So countering some of the news that was out there, there were some people that were saying that there is a UCI student that's positive, isolated on campus, and I thought, I'm the medical director, I should know about this. Like, this is Matt, are you hiding something from me, right? Because these students.
I would have told you.
Oh, thank you. So it's really, it's unfortunately, it's a competition to find what the truth is. And even we sometimes don't have that. And, from the very beginning, and we're having meetings regularly, several every week, just to make sure if anything is changing, everything is we're all sharing that same correct message across our county for sure. And then working very closely with UCI Health and Dr. Gohill and her team to make sure the clinical protocols and procedures in our student health center are the same as what's going on at the medical center. So following the strict CDC criteria, so who fits into it, who gets tested, our personal protective equipment, and I think very importantly, as Dr. Zahn also mentioned, emphasize the message of not just going into the clinic or just going in and just sitting down. So calling us, letting us know. If we're not your healthcare provider because you've got a different insurance plan, do the favor of calling that plan first if you have questions about what's kind of going on with your own health. So we made sure to educate all of our providers, all of our nurses. So, if there is a questionable case, like Dr. Zahn said, don't come into the waiting area. We will will have our nurse kind of meet you at one of our side doors, bring you directly into the isolation room. We have protocols so that if labs need to be drawn, they're drawn appropriately, minimizing any type of infection or spread. And we've even made changes to our electronic health record so that as students are making appointments or as our front office is bringing students in, we are screening for those questions immediately. All right, so do some of the changes that are there. Another big important change that we made was working with our partners on the campus as a whole. So all leadership at UCI's Irvine campus have been working, tirelessly. Seriously, when I say that, we're working every evening, building these communications to ensure that there's a clear, strong, consistent message throughout. One of the biggest messages for us is that keeping the campus as a whole as a healthy environment. And that's been supported through our partners at Environmental Health and Safety. One of the big first efforts we made also was to reach out to our housing team. So, we see students every single day that are coming in for illnesses, infections. And, influenza is what worries me a bit more right now about true spread and disease. And these students are going back to the dormitories. So we brought together EH&S, our student health center. We brought housing together and some of our public health partners to educate and train each of our staff and housing. So these student level housing staff to be aware of what they're working with, what they're dealing with, what are their residents coming home with, and just ensuring a safe and clean environment. This involved, hand washing, educational points. This involved reaching out to potential students that might have infection or illness and directing them that right best way, so that on every level we're doing that right best thing. And I think one of the most recent efforts, so I see some of our strong partners here, so Doug from Student Wellness and Health Promotion, and then Dr. Bowden Albala, right, from Population Health. So they've worked together to really start a campaign on campus. So making sure that hand washing, that good smart hygiene, identifying ambassadors in health amongst our students that can spread that right message. So answering questions about coronavirus, putting down some of the myths of what's going on and making sure that there's a smart, healthy environment, right, on campus. That's what I love about this campus. There are so many minds and so much energy and so much innovation to kind of help that right message. And then Dr. Shin, getting to your point about closing campus and suspending classes, from the very beginning, right, we were getting these messages. I don't know if some of you may have seen there's a petition, and I don't know what the number is. Last time I looked, there were about 10,000, right, signatures to close campus with some other demands. And the good thing is we've taken those demands and we've really communicated that right best way. But closing of campus, so we've heard some of our specialists here on the panel what that would really take. So it's really looking at the numbers, right? Identifying that spread of disease, looking at kind of how it's affecting us in the Irvine community, and at what point it's more of a risk for students to go to class than it is to, to stay home, rather than just kind of take the measures to be healthy as a whole. So I answer dozens of emails every day, right, that come from students, staff, and faculty. And one of the big messages that was coming about the petition, I started to ask these students some questions. So what would you do if classes were closed? Would you just stay at home, kind of lock yourself in, right, and not go to the restaurants and not go out to the movies and not go to Irvine Spectrum, right? So, and if you are kind of still going out, are you saying that you feel that the infection control and prevention at Irvine Spectrum is better than here on the UCI campus, right? And then if you're actually staying home locked in, well, what good is it to close campus to everyone else that feels okay about going? I spoke to many of our graduate students, and closing campus would definitely affect like their medical schools, right, or our graduate schools, or our PhD students that are working on projects. There's a larger impact that's there. And it wasn't to say that their concerns weren't valid, but really looking at what the request was based off of. And it's a bit obvious. They're afraid. Right, there's fear as that basis right now for kind of some of our decision making, right? So I continue to see these, horrifying images, right? And these terrible stories. And, when it was asked about what you believe, I'm not too sure what I'm hearing out of China quite yet. I don't think that they're hiding anything intentionally, but everything's kind of unraveling, unfolding. And I'm a health professional, right? So our students and some of our staff and definitely our families, guys. I've gotten some very, heartfelt messages from parents that are concerned for their children. And I think my goal and our goal is to, build that relationship, build that trust, knowing that we are doing our best, so all leadership on campus, to ensure a safe, healthy, secure environment. I just have to share quickly, there was a parent that sent me a message, and he said that his daughter's here, a student, right? Luckily, she doesn't have any infection, and she'd been in the country for more than 14 days. That's our cutoff point. But he said, Dr. Chang, we just can't get a mask for her. Like, they're all sold out. Please, I'll buy a mask. Just give my daughter a mask. And he was calling me or emailing me from China. So this father is in this country where things are going on, and his concern is for his daughter across the world. So it's very heartfelt, right? So this fear, this concern is very real. But I think the big message is, it's very difficult when you start making decisions based on fear, right? You're not thinking rationally, or you're making assumptions, and you may end up doing the wrong thing, So there was a very wise person who once said, fear leads to anger, anger leads to hate, and then hate can lead to suffering. Does anyone know who said that? Right, so that was Yoda, right? So everything I need to know as a medical director, I learned from Star Wars, right? But you think about that, and you kind of, I always asked why? Why is closing campus a good thing? And I ask my students that I see, and some of them admitted, well, Dr. Chang, it was just kind of a fun thing to put my name on. Wouldn't it be kind of cool to close campus? But look at the impact, right? Look at the real impact of what it does. But more importantly, let me know, right, what information you need to feel safe, what information you need to feel secure, and we can communicate that further. And there's just another thing just to say, some of the emails that I'm addressing, there's a bit of concern potentially with a very large population. We have a very large international student population here, and even those that are wearing masks. So some people are confused by this. Does it mean that they're sick, and they're coughing? And does that mean, that they shouldn't be in the room, or why are so many, people walking around with masks? And so I think it's important for us to just emphasize that, we're all committed here, students, staff, all of us here, right, to creating this culture of compassion, right, an environment of caring. And, the statements that we make around people that are, sick or not sick, or travel who have not traveled, it has sometimes a deeper impact. So I think be very careful, right, about the words that we choose. And once again, don't say anything based out of fear, right? Think about truly the impact of what we're saying. And, we truly cannot keep this campus healthy without the help of all of us, all of our understanding. So we're committed to continue to move forward. The health and well-being of the university as a whole is our top priority. But we're doing it with feedback from you all.
Thank you so much. So my next question is for Dr. Gohil. So we're going to kind of switch gears a little bit and move from the campus setting to the hospital setting. And Dr. Zahn showed some data and some slides about the risk that some patients and healthcare workers might have from getting infected in a hospital setting. So can you talk briefly about sort of what measures are in place in the hospital setting, both at UCIMC as well as other places in the U.S. To sort of be prepared and to protect from nosocomial, from hospital-based transmission?
Okay, great. Hospital infection prevention is a group of individuals, an entire field dedicated to understanding how it is we can prevent the transmission of infections within the hospital setting. The hospital ecosystem is very, very different. We have patients who are incredibly immunocompromised, right? Patients who have almost no immune system, for example, that could walk in through our doors and are potentially exposed not just in the population, but when they're in the heat of our treatments, that can be pretty intense in the hospital. We've got to make sure that every single person that comes into our facilities, whether they are in outpatient facilities or the inpatient facilities, are fully protected. And so, today we're here talking about novel coronavirus, but as Dr. Zahn mentioned, measles, influenza, these are daily activities and daily concerns that we have, and part of the reason why our department even exists in a hospital. There's a small army of people almost in every hospital that you walk into, depending on the size. That army can be big or small, of people dedicated to monitoring and surveying for infections, infection risks as they come in, or threats that might be out there that have not come in yet. Of course, we're in the heat of influenza season. We have measles that have been, and a couple of outbreaks that we've had. We have protocols in place for each of these things. Each pathogen has its own transmission dynamics. We understand them. We have policies and protocols. For example, when novel coronavirus came up, of course, coronavirus, we've known about it, Middle Eastern Respiratory Syndrome, MERS, CoV. This is a virus that has been out there, not as infectious to others, but it's of concern. In Orange County, we have a significant amount of people who might travel to that region and become sick with it and require hospitalizations. We need to have protocols to prevent transmission and spread in the hospital. So it is a coronavirus, and as this novel coronavirus does, the MERS-CoV also requires similar protocols. And so when we heard about novel coronavirus, we had been keeping our eye on it and started dusting off all of our policies and protocols, which actually are stand at the ready for any patient that may walk in at any moment. But we need to sometimes retrain. We train our healthcare workers on an annual basis. But when something like this happens, we go and take a look at our policies, see how well they match up all of our protocols with what we're seeing as the new transition dynamics. We look very closely at our public health partners for guidance, and we take their guidance and then sort of translate it into an operational outcome for the hospital, so that we make sure that we can actually put things into place. For example, when novel coronavirus came up, we already had measles screening, travel screening at all ports of entry in our hospital. We added in travel to China. That was fairly easy. If you think about it, it's just adding travel to China. We've got to make signs. We've got to make them translated into the simplified Chinese, so that people who are at risk can actually read it. We've got to put in our IT systems, electronic health systems, and get them up and running, and make sure that we put in the right criteria for all front desk and back desk staff to capture. We all know about the Swiss cheese model. When all the holes line up in just a way, then somebody can kind of get right through, right? So you've got to have multiple barriers, right, before a person actually gets in. And then once we identify, our goal is to cast a net as wide as possible, get the word out, and if you find somebody, just like Dr. Zahn said, you place a mask, get them out of a waiting room, put them in a room by themselves, and get our healthcare workers in the right gear, and get them to interview the patient properly. And then if those people need to actually come in and get care, we're dedicated to giving care. We do this all the time. Tuberculosis is an actual airborne disease. A novel coronavirus, we use airborne precautions, but it's a droplet-mediated transmission as far as we can tell. Measles also airborne, so we have ways in the hospital once they come in to make it so that you don't even share the same air as the person who comes in and gets hospitalized and has may have novel coronavirus. We have our protocols for personal protective equipment, the way in which the supplies are kept, the way in which they come up, and make sure that we have enough levels of supply adequate, not just for the patient that comes in, but for the patients who may come in, and what is our plan to expand the need for more supplies and the care of more patients than maybe the number of airborne rooms that we have. What are we going to do if there really is a pandemic? So all that kind of planning kind of takes place. It's been happening every year. This is the bread and butter of our job. But when a new virus presents itself, it also has its new nuances, and we respond to those as well.
Thank you for that. And can you talk a little bit about some of the challenges that you're facing while preparing for this potential spread of the novel coronavirus?
Yes, I think very much the same challenges that I think probably Dr. Zahn and Dr. Chang already mentioned. It really is centering around what you don't know about something always is scary. An external threat always looks bigger than what's in front of you. We have 15 million influenza cases, and yet we're focused on the 12 that came imported from another place, just to put it in perspective and not to underplay coronavirus. It's important. We have to keep our eyes on it. But the challenge is when, patients feel like they need a mask too. And we have masks at all ports of entry, and patients, of course, higher volume of people needing them and wanting them these days. And then trying to explain if we don't have the supplies available at that time, patients can get upset. We've had a couple of cases where patients have come in to the hospital and had remote, maybe some sort of exposure to somebody who may have been in contact with somebody who may have come back from China, and sort of really talking and educating patients about this. So that's actually a lot of effort went into producing documents that could be patient-facing enough and explain and calm people down enough. Healthcare workers are also, they're on the front lines. We have all ranges of healthcare workers. We think about doctors and we think about nurses a lot, but there's an entire army of people who are not doctors and nurses who really dole out care on a day-to-day basis and are on the front lines, and then making sure that they're feeling okay and protected, and being able to speak to them. I think that would be my biggest, and the role of the media really, I think it can be a double-edged. We really need the information to get out there, but certainly in the right way. And so I think they've done a reasonable job here, but there has been a spectrum.
So that's a perfect segue for my next question, which is for Dr. Holman. So you've studied media coverage of previous outbreaks and their impact on public health. And so my question is, what have you learned from what the effect of the types of media coverage that outbreaks get on sort of population health? And of course, the novel coronavirus has been getting a lot of media attention. And what's your opinion about the type of coverage that we see in the media right now?
Thank you. That was the perfect segue. Thank you. So my area of research, one of the things I study is the role of the media in spreading concern about various forms of collective stressors and traumas that we experience. I've studied 9/11, I've studied the Boston Marathon bombing, the nightclub shooting in Orlando, Florida, Ebola crisis, hurricanes, you name it. But one of the things one of the most important issues that we've found with the role of the media is that soon after major events that impact the entire population, like these kinds of events, we find that the media's sort of hysterical, and it's often in the hysterical frame, it's sensationalized. And what that does to the population is it tends to increase the amount of anxiety, and there's a construct called acute stress, which is early post-traumatic stress symptomatology. And we find that in large samples of the American population, and these are representative samples, we find that people who are most exposed to media coverage about these major events tend to have the highest levels of acute stress. And in the Boston Marathon bombing, we've actually found they had more acute stress than people who are at the site of the bombing. So yeah, O is right. It was pretty remarkable. So the media can actually spread fear and anxiety, as Albert was talking about, the importance of that. And we've found in our work that as I said, it increases acute stress, but it also increases the degree to which they have subsequent fears and worries about new events that are going to happen. So after 9/11, people became more afraid of future terrorism. And after Ebola, people became more afraid of future exposures and future epidemics that they might experience. And so what we've found in our research is that both the amount of media exposure that you have and what you see in that media exposure can actually have an impact on the levels of acute stress that you experience, the levels of anxiety you're having, the levels of fear that you have about the future. And all of those things actually map into a threat to your physical health as well. I don't know how many of you guys know this, but fear and anxiety and all of those things actually activate your cardiovascular system. And we found in our 9/11 study that people who had the highest levels of acute stress following the 9/11 attacks actually had increased incidence of cardiovascular ailments over 3 years after the event. So, and that was a nationally representative sample as well. So we have found that these kinds of events can have significant mental and physical health impacts. After the Ebola outbreak of 2014, you may remember how the Ebola crisis was handled in the media, and it was rather hysterical, if you ask me. And basically what we saw a couple things. We saw this exact same pattern that I just described. We saw that people who had greater amounts of exposure to Ebola-related media also experienced higher levels of acute stress related to Ebola and higher levels of fear about future exposures and whatnot. And those fears, actually, what we found in our work is that those fears actually can lead to impaired functioning. So people have a harder time functioning in school. They have a harder time functioning at work. These are the sort of downstream mental health and physical health consequences that we've seen. We also saw post-Ebola that individuals who lived in neighborhoods that had a higher concentration of foreign-born individuals and people of African descent, whether they be African Americans or African immigrants, people who lived in those kinds of neighborhoods had higher levels of somatization and anxiety and you may remember after the Ebola crisis, there was a great deal of xenophobia in America, and we found that there were places where parents were saying to schools, just like Albert's getting messages about their kids being protected. There were parents saying to schools, have you taken those black kids out of the schools? And it was not evidence-based at all, because the risk to Americans from Ebola was so small, so small, that it was completely disproportionate with the risk, but people did that nonetheless. So that's the stuff that we've seen in our prior work. And you wanted me to talk about how I see that mapping on. So the coronavirus, we've seen a lot of the same kind of thing, a lot of media that focuses on these extreme negative events, right? That's what draws our attention when we see the super sick person or the super sick, the super scary statistics, right? And when we focus on that, I think one of the things that's really important to remember from a research point of view is that you're only focusing on a small portion of the whole epidemic, because there's a lot of people who have contracted this virus who have very mild symptoms, and they're not being, you're not seeing them. You're not seeing somebody saying, yeah, I contracted the virus, I didn't feel good for a few days, and then I got better. But there are people out there that have had that, but they don't talk about that. And so from a research point of view, that kind of exaggerates that negative aspect. And when you have I really want to thank you, Sanghyuk, for doing this, and all of the speakers, because I think it's really important to get to get accurate, factual information out to the public, and it needs to come out from people who have an ability to persuade the public and get the information across. When you lack that ability to communicate the accurate information, what happens is that rumors start. And what happens when rumors start? People start popping up on their phones, and it goes to social media, and everybody's like whipping around on social media, and oh, did you see such and such, and did you see such and such? Spreads like wildfire, and that's the virus that I think is more important right now for us to contend with, because that stuff is going all over the place, and there's media websites that are spreading disinformation everywhere. So what do? The World Health Organization has done something really great, brilliant step that they've taken. They have a Mythbusters website that they created, and it's about a Mythbusters website about the novel coronavirus. They are going out to all the social media company leaders, and they are saying, when you have somebody Google the novel coronavirus, we want you to automatically pop up to our website on novel coronavirus Mythbusters from the World Health Organization, so that you automatically populate the field with that as like at the top of the thing, so that they go straight to the correct information. So that's one thing that they're doing, which I think is novel, it's great, and it's a very smart thing. So they've already done this with Pinterest. They're going to Google, Facebook, Amazon. They're going to all of these major social media and web-based places that you can go to get them to actually pop up correct information, which I think is wonderful. And the other thing I think that you can do that I think is really important to address this issue, frankly, is, to just, two things. One is to just tell people accurately what the information is that you need to know. Point out that when you get hysterical and when you get all worried and get all scared, it's not good for you. So tell people to not pay attention to so much media about it, but to pay attention to sites where they're going to get accurate information. And then also to have people recognize that, maybe the best thing you can do is model appropriate behavior for others to see. So, if you have to cough or sneeze, you cough, you get what I'm saying. You use Kleenex, you throw it away. You wash your hands, right? The New York Times had another article today by a pediatrician in Indiana. It was a beautiful article. It was very simple. It was wash your hands for 20 seconds with soap and water, and then rinse it off. And then dry your hands. And then, make sure that you don't touch your face. Don't go touching, shaking hands with sick people and touching your face. And wearing a mask, you don't need to wear a mask unless you're sick. It doesn't work the reverse way, as these guys have been saying. So this is information to get out there to help quell some of the anxiety and quell some of the fear that's out there so that people actually don't develop more of the mental health and potentially downstream physical health problems that can stem from this disinformation being spread in the media.
Thank you, Dr. Holman. So I think we've gotten multiple perspectives on the coronavirus outbreak, and now we have some time for questions from the audience. So please feel free to come up to one of these mics to the right and to the left, and if you can just briefly identify yourself and pose a question, that would be great. Thanks. Yes, please.
Thank you. My name is Don Forthall. I'm faculty member here at UCI. It just struck me that something that Allison said, Dr. Holman said, that tied into something that Dr. Buchmeier said as well. That was in regards to the mutation rate of coronavirus and other viruses. So Mike talked about how they can mutate, and immediately the media grabs onto that and suggests that these viruses are going to mutate toward a more virulent form. But in fact, they may just as well mutate toward a less virulent form. And I think Mike can probably tell us that that's exactly what happened in the case of SARS. And if you think about it, a virus, its evolutionary advantage is to have a host that's alive, not one that's dead. A dead body is really a dead end for a virus, particularly when it comes to a respiratory virus.
That's absolutely true. If you think about how a virus emerged, if you have a host, a zoonotic host, let's say a bat, and that bat carries the virus, the bat doesn't die because of that virus. The bat maybe die for other reasons, but when it's transmitted to another individual, it's not a perfect adaptation to that individual. So it may cause no disease, or it may cause very severe disease, or it may cause something in between in that individual. But if it's causing severe disease, that means that the limitation will be survival of the virus in that host. The virus doesn't have a conscience. A virus is just a set of DNA or RNA that infects an individual, and as long as it's successful, it's produced, and if it's not successful, it's gone. It's erased from evolution. So if the virus is successful, it usually becomes less virulent in the human host rather than more virulent. And that's exactly what happened with those cases that evolved in China. As you went further into the epidemic, places like Singapore, there were human cases, but the mortality rate was much less than it was in the initial months in China and Hong Kong. So it is a fact of infectious disease that these things will become less dangerous. Will you ever become a carrier? Maybe. But that's a long way in the future. You will develop an immune response. Remember that if your immune system is competent, every time you go into a grocery store or every time you go anywhere, you're exposed to viruses. And the reason you survive is because your immune system is adapted to respond to those. And it's not the single response, but the additive response through childhood, adulthood, your whole experience in life. When patients, the elderly were sampled 10 years ago, and people were 100 years old. And the 100-year-old patients still showed evidence of an antibody response to the 1918 flu. And that's because that response is very durable and has a very long memory.
Thank you. So question over here? Yeah.
Yeah, I'm a neuroscience in UCI, so I have three questions. So first one is, I think it's very, you kind of show me and you say the mask didn't make any difference. Could you explain a little bit more? Because right now, everyone in China is crazy and buying masks and ask everyone outside, and even we have some association, we donate a lot of masks, try to buy it. Someone donate money, we try to buy it, but it's out of stock. So it's running crazy. So could you explain a bit this, at least come down someone if it's true and or no? And the second one is about the virus, and there's some rumor saying this is coming from wild animals, but also another rumor saying it's coming from some institute, and from the Wild Institute. And do you have any idea about where it comes from?
Okay, so let's see. I think the first question about masks, Dr. Zahn, do you want to take a shot at that?
Sure. I think it's a question we've received a lot of times in Orange County because, and I think on UCI's campus, in fact, seeing people wearing masks has become not an uncommon thing, as was mentioned earlier. So if you are a healthcare worker in a healthcare setting and you are wearing a mask and seeing someone who has respiratory illness, there's good science evidence saying that makes a difference. If you are someone who is sick and you go into a setting, there's at least some plausible information to say that will make a difference. So if you are someone who are sick, once you have illness and you go into a facility and you're worried that you have coronavirus, wearing that mask makes sense. I think for the idea of wearing masks generally around the community, there's really just minimal evidence that makes any difference. I think for us, it's really important to, you go where the money is. And for us, from the CDC's guidance, from the WHO's guidance, from the experience that we have with coronavirus, just about most all viruses, your exposure risk comes when you have close contact for a significant amount of time with people. So, walking by somebody in the hallway always makes people concerned that sort of casual contact, the sort of stuff that's going to make a difference for you wearing a mask, really doesn't seem to be the driver of this or other infections. So I'm at Orange County Healthcare Agency, we're not the mask police. If people want to wear a mask, it is not our job to make people stop actively wearing masks, but I would say that there's really just not much evidence there that wearing that on a regular basis makes a difference for average person walking around with their health.
So Dr. Chang has a comment, and then Dr. Holman.
Masks became an issue on our UCI campus as well. Initially, we kind of made the surgical masks. There's two basic types. There's a surgical mask that typically is what we see, and then there's the N95, which is more for healthcare workers that has to be form-fitted, right? And that's kind of that style that can be preventive. So we made masks available, and they were just disappearing. People were grabbing them by the handfuls. And we know now there's a shortage, right? This is why the worst case scenario is when even healthcare workers can't get masks, right? So we've been working with our environmental health and safety, once again, to ensure that, we as student health, right, we kind of get the priority for N95s, right? And then we're also covering interestingly enough, our police department, right, are oftentimes put into situations where they don't know the environment. So police department, they're all trained with masks as well. We are providing surgical masks for sure to those students that are coming in with respiratory infections. So if a student comes into the student health center, no travel to China, no positive contact, right, but has something, we're asking them to mask. If you come in for your twisted ankle and you're worried about the guy sitting next to you, I'm probably not going to give you a mask, right? But as Dr. Zahn, as Matt mentioned, but there's no judgment here, right? So it's if once again, for that father, just getting his daughter a mask made him feel so much more comfortable, right? And there's an article I've been sharing from a writer, a Chinese writer, who was, during the days of SARS, so in 2003, he was reporting how his daily routine, he and his wife would come home, take their N95 masks, put them in like the disinfectant, completely disrobe, put all of their clothes into a sterilizer, right? Go to their showers, clean completely with, right, their disinfectants, dry off, and then start taking care of, like, start dinner or take care of the kids. And this was their routine, day after day for months on end. And so that was the culture, right? That was the culture of kind of protection that they had, that they grew up in. And, you know, our students, they were probably infants at that time, some of them, but that's the culture they also grew up in now. And that's why, you know, there's really, when you look at someone wearing a mask, what does that mean? It means different things. Now, we as the medical professionals have to just kind of make sure it's not going to keep you from getting coronavirus necessarily, right? It may keep you from spreading something else, but, you know, masks and mask availability. I never thought that, you know, a mask on a face could make such a difference, right? But it means different things. So once again, not being judgmental, right? Allowing for it. We've had some staff members or some managers ask if someone is coming in from a certain country, should I force them to wear a mask? You know, and that's a hard question. Or I had another student say, you know, I'm sitting in my classroom and there's half a dozen students wearing masks. Should they even be in the room? You know, so a lot of difficult questions that occur. And, you know, following what Allison had mentioned about just the level of stress and anxiety that starts to build, I wanted to mention for our students, for sure, we've been working very closely with the counseling center. In fact, I know that we have a Dr. Choi here that's kind of supporting our students in that effort. In addition to our counseling center, we as student health, right, have mental health services and providers and social workers available. And on top of that, we're also working with our International Student Center. So, you know, it's really working with a defined population. And I'll just state also, so we're working with Victoria Jones to really maybe identify, she's our Global Affairs Officer, you know, identify a student group that can, you know, international students can really speak from their perspective. So number one, how do they kind of get news and how do they, you know, process information? Coming from international students that may have family in Wuhan currently, may have suffered already from this situation, you know, once again, living a half a world away. And then what I want is, number one, feedback on our communications, what's working, what's not really working so much, but then coming up with innovative ideas to kind of spread a good, strong message. So for the mental health challenges and difficulties that are out there, right, we're very, very attuned into that. We're seeing it affecting, once again, not just kind of mental health, but physical health. And, you know, our students are in a pressure cooker here at UCI anyway, right? This is one of the top academic institutions in the country. It's no joke. The last thing they need is something that's compromising their academic health, their academic success.
Dr. Holman, did you have a comment? No. Okay, so I think the second question was about the origins of the virus. I wonder if that's Dr. Neumer or Dr. Buchmeier or Dr. Menon, perhaps?
The coronaviruses are actually part of a larger group of viruses that we call nidoviruses. Why, you ask? Because people who name viruses like to change the names. But it means nested set. And so what happens is these viruses have a nested set of RNAs. It's very arcane, but they have that in common. They exist as very small viruses and very large viruses. It happens that the coronaviruses that we're talking about have the largest genome of any RNA virus. It's about 32 kilobases, so 32,000 bases. The smallest ones are only 6,000 to 8,000 bases, so they're very small compared to the coronavirus. Where did they originate? We don't fully know. We don't think that they're in insects, but we do know that they're in bats and they're in many other animal species. They've been found in pythons, for example, in South Florida. So we don't really understand fully where they came from, and since viruses don't leave fossils, at least durable fossils, you have to deduce where they've come from establishing the relationships. And we're still really in the process of discovery. One thing that we learned as a result of the SARS epidemic is that SARS was not a new virus at all. SARS is a virus that exists in bats all over the world. MERS was no surprise then, because we saw SARS and saw the distribution of SARS. And now this virus should be no surprise because, again, it's in bats, at least it appears to be in bats. And it is distributed in an area in China where already we knew that there were bats that were infected. So it is rather arcane to trace these down. The genomes are complex. The diversity of the genomes is complex because of the high mutation rate of the virus. And the number of host species is often undetermined until an epidemic or some other event that drives us to look at them. So the short answer is no, we don't know.
I just wanted to add, so I've seen the references that you mentioned about origins of the virus tracing to some strange places. If you want to look more, if you're into nerdy epidemiology like me, I would recommend going to a site called virological.org. It's run by one of the best evolutionary virologists in the world, Andrew Rambo, in the University of Edinburgh, and it has actually a lot of debunking of those myths about this origin. The most recent little article that this website published traces the virus, not it traces, it identifies the closest relative that we know right now is a virus that was sequenced actually from a bat in 2003 in Yunnan province in China. The best estimate of the time to the most recent common ancestor, which is the common ancestor of these two the most closely related viruses, which share 96.1% of their genome, so it's very closely related, is about early 90s. So that's the common ancestor. So basically all the myths that have been put out have been debunked about these, someone in the lab developing some virus and it escaping from the lab. I think it's a complete misinformation so far, according to all the data we have. So far, no data supports any of that. It's a very simple zoonotic event where the virus jumps from one species to another, in this case from a bat to a human, and then human to human transmission occurs after that. It's very simple parsimonious explanation that probably is most likely.
Thank you. Dr. Hallman?
Yeah, I just wanted to, I appreciate your bringing up the fact that there's another website to help bust myths.
Yeah.
Because myth busting in a situation like this is exactly what you have to do. It's the disinformation that's out there, there's so much of it. And there's a group that this morning I labeled them in my mind, clickbait capitalists. These are people who go out there, they find something that makes you click, right? And it scares you and it gets your attention, and then it pops up something that they're going to sell you to get rid of that fear. And it's an intentional thing that people are using, and it's a way to try to make money. People are making money off of scaring you and then selling you something to help you deal with your fear. So be aware and pay attention to these accurate websites. The World Health Organization myth busting. My friend's site. I couldn't say it over again because it was too complicated.
Virological.org.
Thank you, virological.org. So, I think that's really, really important. The CDC is a great source of accurate information, and just paying attention to that and like we look up on Snopes, we look up to find out if things are actually true or not true. We need to start doing that with all of this information from SARS. If your instinct says anything that it might be weird, or this seems a little like it's clickbait, stop yourself, check it out before you spread it.
I think that's a good opportunity for me to plug our website, our Infectious Disease Initiative.
Perfect.
Website. We have a resource page set up with links to the Orange County Healthcare Agency, the coronavirus page, WHO, CDC, the UCI Student Health Center. So we have links to the trusted sources. So please feel free to check our website. And I think we have time for 2 quick questions and 2 quick responses, so please go ahead.
So this is a perfect segue, and I just want to say thank you very much. My name is Imelda, and I'm an RN case manager in Irvine, Silverado. And my question is very weird. I understand that there is a biosafety level 4 super laboratory in Wuhan, and that they were developing this mutation from the SARS epidemic to release as a biological weapon, and also that there was some gentleman that was arrested in Canada with 12 vials of this secret virus in his socks or something, so I'll have to go to Snopes, and I just want to thank you for taking the time to come out and help us understand and support, give us some more information. Thank you.
Thank you.
Thank you.
Can I just say, I don't think that that's weird, and I think it's actually healthy, especially because a lot of mistrust in our society right now, political world, and I think it's healthy to ask those kinds of questions.
Thank you for that.
Can I piggyback on that? Is there a way to get the information out to the community? I mean, we all know the CDC. My name is Rachel Roberts. I'm with Institute for Healthcare Advancement, and I also teach part-time at Cal State Fullerton in the School of Public Health. So we know the CDC website. We know the healthcare agency website. I learned about your website today. But is there a way that we can help the community understand where to go? I know some of my community partners have been asking how to handle questions from the public and what they can tell them and where to send them. Is there a way that we can get this out to the public and tell them where to look for the right answers, or a simple plain language handle? And you mentioned, what we know, what we don't know, and I guess I'm really looking for some more information to share with the public for those who don't go online and don't know where to go.
Yeah, I guess the thought I'd have is from the healthcare agency side is, would that there was one way to get the message out. Unfortunately, it is, for us, experiences that we have to do it in about a dozen different ways or more to have effect. I think that we're really good at getting out to healthcare providers. We are really good at schools and school nurses. We're extremely attached to to entities like that. I think we're really attached to the universities. I think that, but other places, the short answer for me is I think we find out every time we have these events, different groups that we can better reach out to. So I don't have an answer for you other than to say, we're always open to that conversation of saying, if you see there's a community group that you think is not being reached and can think of a way to help us do it, we always want to be part of that conversation. Put it that way.
Yeah, sounds like a new collaboration waiting to happen.
A sidebar afterwards, yeah, absolutely.
Okay, so final question, please.
Thank you very much for the event. I'll bring this here so I can actually see people's faces, if that's okay. Unfortunately, there was actually some other questions from colleagues who were watching but couldn't make it that wanted to ask as well. If they're quick enough and there's time to answer, please. But there might be also something that will definitely be too long for feedback, but I think it's worthwhile to get a little more attention to. First, there's been some reports of possible viral spread, as was the case in SARS, it seems, through excrement. So, for example, fecal matter also contained viruses, and in case of airborne transmission, whether that might be a way. So the case of the cruise ship right now in coast of Japan, there is some concern that some forms of quarantining people might still leave people kind of exposed to different forms, and consider also the fact that in China a lot of the plumbing system, kind of like the sewage smell just comes up through the plumbing like all the time. That's something that I think is in the debate around China, that's in the conversations about what we know, what we don't know. There hasn't been a lot of information about that to be addressed. There's also some questions more close to home here, and I really appreciate Dr. Chang for all the hard work you've been doing on this about mental support and emotional support for students and the faculty and their staff.
Yep.
I'm sorry, I forgot to identify myself. I'm Gustavo Oliveira. I'm a professor here in the School of Social Sciences, and we're seeing really dramatic racism happening on our campus.
Yep.
Students of Asian descent or Asian appearance are being, in various ways kind of like pressured to corner themselves onto a classroom. They're being pressured to not come to class. When the students wear masks, they're treated with dramatic disrespect, and when they take off the mask, those students suffer a lot more anxiety.
Yeah.
Because in their understanding, that is not just a way to protect themselves, it's a respectful thing to do. And I want to add to this conversation around racism, this concern about the lack of information around mask wear. And I understand Dr. Zahn already gave some information, other people as well, but from what I've done in my own research about this, the studies are really thin. So what happens, and this is true, you get a major news outlet in the United States that is saying masks don't work. and I go see what is the scientific paper that journalistic piece is talking about. It was a study where it was a group of just masks, no hand washing, nothing else, and a group that had masks and everything else, and a group that just hand washed. And they say, well, of course, just wearing the masks but not washing your hands or doing any other things did not have a significant effect. That's very different than saying masks don't work.
So sorry, I think you're making really valid points, but we're running out of time. So if you can just pose a question regarding the masks.
Can you post these informations about mask wearing, and can you also talk about herd immunity and the way that in China, masks being used by all the people are a way to actually perhaps reduce the spread in a way? I mean, you're not going to tell people, oh, don't use condoms, because they're not 100% effective, especially to vulnerable populations. I think that there's some problems there in the conversation that at least we could have more information about. And also, I'm sorry.
No, you're making really valid points.
How do you deal with the racism that comes with this?
Yeah. No, those are very valid points, and I think they need to be discussed. We are running out of time. We have 6 minutes until the hour, so I want to invite the panelists to address. I think the first question was about. Something about the virus.
So shedding in stool.
Shedding in stool.
So the virus has been identified to have shed in stool, and so the impression that from what they see in China is, again, you kind of, to begin with, you go where the money is, and the best evidence that we have is the major source is still respiratory illness and as a spreader. I would tell you that as we're thinking through for the initial cases that we have in the United States, and we decide when is someone not infectious anymore, stool and whether stool testing is valuable or useful is absolutely something that we are thinking through. Again, we're trying to be very fair to not just our case, but everybody in the country. These initial cases, you want to make sure that public is safe. At the same time, you want to be fair to them. One of the things we're doing is we're doing testing of different sources to identify whether there's a potential source. So I don't have an answer to it other than to say stool is a potential source. I think we're all comfortable it's not the primary source, but whether it could be a source and whether there needs to be some guidance around that is something that's certainly a concern.
Thank you. And I guess last question about the races.
There are two considerations about the stools that you need to keep in mind. One is that most of the animal coronaviruses are enteric infections. So if you look at if you look at the porcine enteric diarrhea virus, for example, it exists in two forms, in a respiratory form and in a GI form. The observation of RNA and possibly virus in stools was made during the SARS epidemic as well, but stools were never associated with infectivity. So the fact that the RNA is there is one thing, but that doesn't tell you that the stools are infectious. So I guess at best you could call it an open question, and that's exactly what you said. Yeah.
So Dr. Chen, do you want to take on the last question?
Right. So I mentioned a bit. Thank you for bringing up the larger concern, right? Because we don't always see everything that's going on. So a statement from our leadership, for sure, regarding this issue that is growing and is becoming more and more aware. We actually have some people from our departments of humanities also working on this to form a message that's together. Reaching, I think, out to our students also that are feeling this effect to really get their stories and share a bit of their stories about what truly is happening. And then I think, once again, this is a part of all of our job as the UCI community to kind of create that right environment and culture. So we have so many, right, potentially marginalized populations on our campus. So it's just, making sure that we continue to communicate, right? So before, it's the fear, it's the judgments once again. It's these assumptions of I'm going to get something or I'm going to catch something that's going to be harming me. So instead of just jumping quickly to that, like take a logical thought, take a step back, think about what truly is concerning you, and just treating each other with respect, with dignity, right? We all are here for that same effort, right? We're all trying to do that best. We cannot create this without all of us kind of participating and vocalizing and verbalizing, right? I'll share with you guys, I don't know how to really focus on it so much other than just to share what I think is best, what we all think is best, right? And to perpetuate a kind of that, that environment of support. You know, if there are ideas, if there are, you know, solutions, that's where we're working with our students to really identify that we can attack this and approach this more, you know, productively, more directly. I'm welcome to that also. Yeah, your concerns are very valid.
Yeah, no, another actually really important collaboration. I think we need to get together, like you said, and unite and make sure that that incidents of racism will not be tolerated on our campus or in our community. I absolutely agree. Okay, so with that, I think it's a great time. We're out of time, and let's give the panelists and Dr. Zahn a big round of applause.